Welcome back to the 2025 APAICS Health Summit. I'm Madeline Milka, President and CEO of APAICS. Our next panel of the APAICS Health Summit is AI and Emerging Healthcare Technologies. A recent survey found that 77% of health executives indicated that AI is among their top 3 priorities for investment in the next 12 months. Emerging technologies can help improve patient diagnosis and treatment by analyzing vast data, identifying patterns, and providing personalized insights. This panel explores how technology will change the quality of care and the overall patient experience. Next, I'd like to introduce CAPAC Executive Member Senator Mazie Hirono, who represents the state of Hawaiʻi. Senator Hirono is the first Asian American woman and the first woman senator from Hawaiʻi. She has demonstrated a lifelong commitment to addressing health disparities, starting with her volunteer work at a local mental health facility in college to her advocacy for affordable health care and personal health care privacy in Congress. Please join me in welcoming Senator Hirono.
Aloha. I'm Senator Mazie Hirono, and I'm glad to join you for this 2025 APAICS Virtual Health Summit and this panel on emerging technologies in healthcare. Artificial intelligence and other emerging technologies have the potential to revolutionize healthcare by helping to elevate patient care, alleviating administrative burdens on providers, assisting providers to more effectively diagnose and treat patients, and much more. AI also has the potential to help address long-standing inequities in care and outcomes faced by many underserved communities. For instance, gaps in healthcare access, outcomes, and research are common in groups like the AANHPI community, which often face systemic difficulties in accessing healthcare services, such as language and cultural barriers. The AANHPI community also faces a disproportionately higher risk of dying from diseases such as stomach and liver cancer compared to their non-Hispanic white counterparts. They also face new, disturbing, and unexplained trends such as the increasing rate of lung cancer among Asian American women who have never smoked. AI and other technologies have the potential to close these gaps in care. But if used incorrectly, AI could also exacerbate existing disparities. AI developed using biased and inaccurate data can worsen existing biases in healthcare, leading to misinformed decisions that can negatively impact already vulnerable groups. This is why I have introduced and continue to fight for the Health Equity and Accountability Act. This legislation would address health disparities by strengthening data collection, increasing access to health services and resources, and diversifying the healthcare workforce. As we continue to explore the role of AI and technologies in healthcare, it is crucial that we make decisions using data that reflects the experiences of diverse groups. We must also fight for diverse representation in the healthcare workforce and establish strong guidelines addressing the use of AI and emerging technologies. Integrating the technology will only enhance quality of care if it is done thoughtfully and responsibly. Given the current administration's attacks on diversity, equity, and inclusion, it is crucial that we continue to advocate for diverse representation in technology in healthcare. That's why I appreciate the focus APAICS is putting on this issue and the commitment you all share to improving care for our communities. I'm proud to be your partner in this work and look forward to our continued work together to responsibly harness the power of AI to address healthcare disparities and ensure every member of our community can access the quality care they need. Mahalo.
Now, I'd like to introduce KPAC Executive Member Congressman Ted Lieu, who represents California's 36th District. Congressman Lieu is a strong voice in Congress advocating for technology's role in improving public health and ensuring that its benefits are accessible to all communities. As a member of the House Judiciary Committee and a leader on tech issues, he brings invaluable insights into how emerging technologies, including AI, will shape our healthcare system. Please give a warm welcome to Congressman Lieu.
Hello, I'm Congressman Ted Lieu. Thank you for inviting me to join today's virtual health summit as you convene the panel to discuss AI and emergency healthcare technologies. The intersection between artificial intelligence and healthcare is a growing space, and it has the potential to save lives. At the same time, if used incorrectly, AI can cause harm. I'm glad that APAICS is empowering each of you to participate in this timely, necessary conversation. Last Congress, I co-chaired the House Bipartisan Task Force on AI, where we welcomed experts to Capitol Hill to discuss the possibilities of AI in healthcare settings. We learned that AI is already being used to significantly improve diagnoses. AI has been deployed to assist with imaging and to help find cures for heart disease, cancer, and Alzheimer's. AI is also being utilized to discover new drugs, assist doctors with note-taking, and streamline our insurance process. While these developments are promising, the advent of AI has also raised unanswered questions. For example, who should be liable when an AI-supported diagnosis is incorrect? How can we standardize and integrate large healthcare data sets? In what instances should patients know that AI is being used, and how much do they need to know about the model or algorithm? As many of you know, large language models can do amazing things, but at a very basic level, we don't know exactly how they work. They're so complicated that we can't trace how they get an answer from point A to the conclusion. We just know that it gets the answer right most of the time. But every now and then, the model hallucinates. So you might want to think about in what use cases is that unacceptable? In what use cases do we need the model to be correct 1,000% of the time, every time? For example, can you have AI fill medical prescriptions if every now and then it hallucinates? I don't think we would want that. So considering what use cases do we need a human in a loop or other safeguards, I think would be an important area to explore. I hope that today you engage wholeheartedly with these pressing questions, which will have consequences for patients across our country. As Congress continues to deliberate these issues, I look forward to hearing from you about how AI can help us live longer, healthier lives. Thank you.
I'm thrilled to introduce our next panel moderator, David Inoue. David is the executive director of the Japanese American Citizens League and has spent years in healthcare policy, including with the National Association of Public Hospitals and Health Systems and the Centers for Medicare and Medicaid Services. With a rich background in public health, healthcare policy, and technology, David will guide our conversation on how AI can impact healthcare access and outcomes for diverse communities. Please give a warm welcome to our moderator and our group of panelists.
Thank you, Madeline, for that introduction. And on behalf of the JACL, it is certainly my honor to be here to moderate this panel today. I am joined by Marshall Chin, who is the Distinguished Service Professor of Medicine at the University of Chicago, Mary Joy Garcia Dia, who is the Nursing Informatics Program Director at New York Presbyterian Hospital, and Neal Palafox, who is Professor of Population Sciences at University of Hawaiʻi at Mānoa. So thank you to our panelists for joining us. If we could maybe start off having each of you please introduce yourself, your organization, and how your work interfaces with advances in artificial intelligence and technology. Marshall, if we could start with you.
Thanks for inviting me. My name is Marshall Chin. I'm a general internist and a health services researcher at the University of Chicago. And most of my work centers around trying to advance health equity, defined as making sure that everyone has a fair and just opportunity for health. I got involved with AI and some of these issues of algorithms about half a dozen years ago, working with some folks at Google on a paper regarding algorithm bias. And then most recently, I co-chaired a federal panel, sponsored mostly by the Agency for Healthcare Research and Quality and the National Institute on Minority Health and Health Disparities, which was trying to come up with guiding principles for addressing racial and ethnic bias in algorithms.
Thank you. Mary Joy?
Hi, good morning, everyone. My name is Mary Joy Garcia Dia, and I am the Program Director, Nursing Informatics at New York Presbyterian. I am speaking from the lens of a professional registered nurse and also a nursing informatics specialist. I also wear the hat of being the former president of the Philippine Nurses Association of America. So this topic is really close and dear to my heart because a lot of people ask, what is a nursing informatics specialist? And I always tell them that I work with so many technology experts like computer programmers, our technicians, and also our clinical providers who are promoting safe quality care in our healthcare organization. So in a nutshell, when they ask me, I'm really telling them I'm a computer nurse. And I think this topic is very important because the use of technology as a tool in healthcare is critical in the overall management of patient care as we deal a lot of data as the internet continues to collect this data as part of our personal information. This is where our work, especially informatics, come about. So I'm very happy to be part of this discussion.
Thank you, Mary Joy. And Neal.
Yeah, aloha kakai haka, everyone, and yakwe kom. My name is Neal Palafox, and I'm a professor of family medicine and community health at the John Burns School of Medicine, and also a professor of population science at the University of Hawaii Cancer Center. Everything I'll be speaking on, as many of the others, I believe is going to be a personal opinion. I do not represent these organizations in what I'm speaking about. And a large part of my work is about cancer prevention and control in the Pacific and addressing risk reduction and using the appropriate interventions in these areas. Unique to what I do is I work in the Pacific environment, which means I work in the 3 United States Pacific Island territories of Guam, American Samoa, and Commonwealth Northern Marianas, as well as 3 sovereign nations that are linked to the United States by a treaty. And they are the Marshall Islands, Republic of Palau, and Federal States of Micronesia. But unique in that population is they're all indigenous Pacific Islander populations. They're all very rural. Some are low income countries, some are high resource. And I actually lived in the Marshall Islands working as a physician and their medical director for 10 years. Over.
Thank you, Neal. Mary Joy, if you could maybe start us off and maybe do some level setting as to what exactly AI is, and particularly in the healthcare setting, and some concepts such as machine learning. Many people have heard of ChatGPT. How does that fit in with what we're going to be talking about today?
Yeah, absolutely. So artificial intelligence has actually been there for many years, I think since the 1950s. It's really trying to mimic how we think, how we're able to predict things, and how we're able to interact with each other. So I think because of the evolvement of newer technology, and of course the power of data processing, now we see terms like ChatGPT, where we're able to now interact with the software applications like ChatGPT, and also Google has come up with its own ChatGPT as well, and able to ask questions and interact, right? So I think the National Science Foundation notes that AI enables computers and other automated systems to perform tasks that have required human decision-making abilities. So it's really augmenting how we do our work. So this way, we're able to process this information in a safe and efficient manner.
Thanks, Joy. Mary Joy. Neal or Marshall, did you want to add anything?
There's a Tom Cruise movie called Minority Report, where it takes place in the future, and Tom plays a police officer. And the shtick is that in the future, they have a system to be able to predict who will be committing a crime. And then Tom Cruise's unit is then called in and they arrest the person before they commit the crime. So this ethical issue of, well, they haven't committed the crime, but we've predicted that they are going to commit the crime. And so in some ways that is like an analogy to the challenge of AI, that it'd be wonderful if we are able to analyze data as Mary Joy said, and come up with findings to help guide ourselves with wise decisions. On the other hand, there's this issue of, well, how did the AI come up with that particular finding? Is it valid or is it biased? And so one way to think about it too is that many people listening probably have taken a statistics course or have had a statistics in one of their other courses. And then you think about something like a line graph showing a relationship between a variable, a predictive variable, and the outcome. Kind of intuitive, seeing like a line graph, like a horizontal axis, vertical axis, and a line relationship. So I said that one of the challenges, though, is that AI uses these huge data sets. So big data, you heard about big data. And the challenge is that it's inductive, it's not intuitive. And it's this black box of like, well, you throw all the big data in and out comes these answers. So it's much harder to judge. So that's one of the challenges for us then thinking about how do we harness the technology, at the same time make sure that the results and recommendations are valid and understandable by us as humans.
Thanks, Marshall and Joy. The way I think about it, and I simplify it for myself, just for the use in the medical field that I work in, is that machine learning is a subset of artificial intelligence, and machine learning is really about developing protocols using, data and finding out which protocol leads you using the right medicines or the right types of tests, so you get to the best quality and results that are based on, some human values at the end. So really it's about, I think of it as in medicine, protocols, how you develop the best protocols. And that's what machine learning is. AI, on the other hand, is the larger rubric, and it's often termed as deep learning from the way that I understand it. And the deep learning not only takes the large data sets and analyzes patterns in the way that it works, but it learns, meaning that if you feed it new information, it can include new information in its next iteration of an answer. So it's trying to learn. It cannot mimic creativity, but some people say it can because it's learning. But anyway, it's taking data, learning from the data, and trying to produce answers. But as Marshall said, it's always based on a value at the end. And that's where it will never be able to, I think, replace humans. So anyway, it processes data to help us understand what the data is telling us.
I mean, one of the things I think you've all kind of highlighted here is the importance of data when we are talking about AI. And one of the challenges, I think, particularly for us in the Asian American, Native Hawaiian, Pacific Islander community, is that there's not always a lot of data about our community. Could we maybe talk about how AI will interface with our community particularly? Maybe we can go right back to you, Neal, since you do work in the Pacific Islander community, which is probably where we have the least amount of data out there.
In the work I do, I mentioned a lot of cancer prevention and control and risk reduction. And as Joy mentioned, technology has evolved in this interface of cancer prevention and control. So specifically, it's looking at ways that you can take the advanced, let's say, imaging techniques. So for instance, if you take mammography for cancer screening, breast cancer screening, in many of these areas, they don't have mammography. Or the mammography they use, they don't have someone to read it. So AI is able to read the images because it can pick up nuances that humans can't read, and you can do it at a distance. So you can use AI to read the images in areas where they don't have mammography that is well deployed, and so it's effective. And because mammography is not well deployed, ultrasound is a technique that in the US, they don't use it for primary screening, but where there's no mammography, it's more portable in the field. So we're working on using AI algorithms to build ultrasound into an imaging technique that can pick up nuances of what's read under an ultrasound, so it can come close to the screening of mammography. So again, it's linking AI to imaging that's not currently used in the field of breast cancer screening to do that. There's a lot of TB that's poorly controlled in many of these areas. They're distant, they don't get the medicines, and so they develop resistant TB. So it's large-based population screening, and what they do using some of the latest technologies, they take X-ray units, and they're actually literally about this big. But what allows it to work in the field and to read the images is they use an AI algorithm to read the images right on the spot after it takes the image, which you need an advanced radiologist for, something like that. So it's image reading. And the last one I just want to touch on is in American Samoa, they're working on some way to do colon cancer screening because they can't deploy the colonoscope. A lot of folks can't access the stool cards that are used for cancer screening. So they actually take the medical records and they screen using AI for whoever has microcytic anemia. That means a type of anemia where the cells are small. And they found out that the bottom 1% or the top 1% that have this type of anemia are more likely to have colon cancer. And those are the ones that are pushed into the colon cancer screening paradigm. So I just want to mention that it's linked to current imaging or other techniques, but that's how it's used in populations that are hard to reach. Over to you, David. So those are some of the things that we are working with and on.
Mary Joy, if you could maybe comment both from the perspective of how do we, the nursing profession obviously works both directly with patients, but also itself is occupied by many Asian American, Native Hawaiian, Pacific Islander staff. You yourself are with the Filipino Nurses Association. So how do you see AI impacting our ANHPI communities, both professionally and also to our patients?
I think this is very important for us to have a step back and remember COVID-19, because I think that's where we saw the discrepancy on how we're collecting information about our Asian Pacific Islander community, especially when you're trying to understand how many people were really impacted by COVID. And majority of the EHR, electronic health record, might already be including social determinants of health, which are very important because this allows us to understand what are the needs of the patient when they transition from the hospital going back to the community. And I think there is opportunity for us to have AI be integrated to make predictions, so to speak. So this way, when a patient comes in and we're able to see that this is a diabetic patient, might not have access necessarily to healthy options in order to manage their diabetes, this is where AI can probably assist in trying to predict where is the geographic location of this patient, what's the zip code of this patient. So this way, we're able to connect appropriate services that could help the patient in managing their care. And this is so true, especially for our underserved communities. So I think those are just like one of the examples that I can think from my end in terms of professionally, how we can use AI. And then at the community level, how do we educate the patient that there are options that they could participate in terms of connecting the dots from their end to manage their care.
Actually, you did use a term in there, social determinants of health. Could you maybe explain that for our audience very quickly?
Yeah, absolutely. So social determinants of health are factors that can be a barrier for a particular individual in the overall management of their health. So for example, if I live in an area that has food insecurity, how can I manage my diet in order for me to have easy access to healthy options, right? Like fresh vegetables, because I'm not able to do it. Economically, if I don't have enough allowance in order to purchase my medications, who can I reach out to so I could afford to maintain those medications for myself?
So perhaps the promise of AI is that it can actually help to sort through these multivariable factors in what determine health.
Absolutely. I think it can improve the insights, right? So this way we can incorporate community health databases, our census data, and also social service records. So this way, from a policy perspective, our constituents who are part of that decision-making process can allocate funding that is important for underserved communities.
Thanks, Mary Jo. Marshall, I know you've been kind of chomping at the bit to jump in on this one as well. Why don't you jump in here?
So I'll give you a concrete clinical example that for many years, the big heart study was called the Framingham Heart Study. Framingham is a predominantly white middle-class suburb of Boston. Does the results and data from this population apply to Asian Americans? Well, we don't know. And there is currently an NIH trial called Mosaic, which, as far as I know, is still being done, which is specifically enrolling Asian Americans to follow over time their heart outcomes. So we have data to understand the factors that are helping or hindering the health and cardiovascular health of Asian Americans. What does this mean for AI? Well, the AI is only good as the data that you use to build the models and then your techniques for developing the models. So, for example, we would want to know, well, did the data that an AI tool came up with, did it include Asian Americans? Do we know how that particular tool performs in Asian Americans? So if it's going to recommend, a health action for Asian Americans, do we know how accurate that prediction or that recommendation is? We need to create that data to build the models. There's a great need to specifically have data sets that include Asian Americans and then track how they perform in Asian Americans, because one-size-fits-all solutions oftentimes aren't the best solutions. Oftentimes, things need to be developed specifically to meet the needs of Asian Americans and to be demonstrated to perform well among Asian Americans.
No, I think that actually provides a perfect segue to my next comment or question. Our target audience for this policy forum that APAICS is doing is our policymakers, people who might be working in Congress or perhaps working at places like HRQ, where you've done some work, Marshall. For those people, what are the things that we need to have in our policies as we move down this sort of unknown place of AI to make sure that our communities are represented, that we are part of that data? What are the things that policymakers need to be thinking about? And Marshall, I'll let you start off.
The key in some ways is that you want to have policies that harness the power both of the free market, because we want to have innovative AI that flourishes. At the same time, there needs to be wise regulations so that we don't have the potential downsides of AICs, for example, policies that can actually hurt folks. And so we've actually sort of seen a change where the Biden administration had an executive order which specifically tried to look at issues of bias and tried to promote civil rights. One of the first actions of the Trump administration was to rescind that particular executive order with the argument of trying to basically remove the regulation, free the free market. And also a clause was that the American development of AI systems must be free from ideological bias or engineered social agenda. I think, again, a wise policy would try to balance the two of, like, you want to, again, enable the power of the free market, at the same time have the regulation which would make it more likely that we maximize the good and minimize the potential biases. And so some of the things I would have on like the checklist of policies would be transparency, right? It's often not in the interest of private companies to be transparent about things like what I just talked about beforehand of like what data they use to create the algorithm, how it performs in different populations, like Asian Americans, for example. Things need to be explainable. So if it's not understandable by a policymaker, if it's not understandable by a basic a layperson, the public, because these AI algorithms are being used on them, it's not clear enough, not transparent enough. Another would be involving the public at all phases of the development of a policy and an algorithm. So again, if you have the public at the table, they're going to be guided by what's good for the public, right? So they need to be involved in terms of discussions about what algorithm is going to be used for, what data are going to be used, how it's developed, how it's going to be monitored. So that'd be another key one. There needs to be accountability, that again, if you leave it up to the pure free market unencumbered, a lot of this is not going to be done. So again, there needs to be sort of an appropriate, wise level of accountability for things like transparency, for example, or ensuring then that algorithms aren't going to be used if they're going to hurt people, right? We're weighing a variety of different trade-offs. So for example, this word fairness, algorithms can have a varying degree of fairness. And from a technical perspective, when you develop an algorithm, there's a trade-off between how accurate is the algorithm for the overall population versus its accuracy in different subpopulations of Asian Americans. So there needs to be that explicit discussion of like what trade-off among the two is adequate, or using the lay definition of fairness, there's going to be variation depending upon how the algorithm is developed with fairness of the outcomes for Asian Americans and the populations, and the fairness of the allocation of resources, because algorithms are often determining how resources are allocated. So there needs to be transparent, open discussion about fairness in terms of outcomes, resource allocation, and then the fairness in terms of how accurate they are for different populations, including Asian Americans.
Thanks, Marshall. Neal, you got a mention there in Marshall's comments. Why don't we have you comment next?
Yeah, I think a lot of Marshall's comments are truly appropriate in the populations that I work with, because one is AI is based on data and data sets, and so is machine learning. Smaller communities that I work with, they don't have the data, they don't have the data sets, they're not included in clinical trials, so you're often applying, these data sets to folks that aren't even part of the data that the AI is trying to learn from, and oftentimes in the work of us trying to be efficient and work quickly, we often forget that some of these communities, one is they don't have the data set, so we have to build that in first, and so the policymakers have to look at it and say, we have to, in order to build an algorithm for them, or the best way to look at things, we have to first build the data. We first have to, and some of it is barefoot epidemiology in a small community of 400 people in the distant Pacific with no electricity and no water. And so to weigh those things and why that's important to do, like Marshall said, the community has to be engaged. They have to understand what this means, because at the end, if AI is producing a way to go forward with an algorithm, or this is the best way to do things, if it's going to affect the community's behavior, they have to believe in that process. And in fact, they have to believe in the science behind the process. And there is an entire indigenous knowledge that is very different from the Western knowledge. It's based on community wisdom. It's not based on, what the large data set cranks. And so it's one of, if you want to affect behaviors, their behaviors are based on not going to be on the outcomes of an AI algorithm. It's just not even going to apply. One of our sensibilities, I think, in Western medicine and Western science is that data belongs to everybody and that you can process whatever you need to do. Whereas I think a lot of these countries have been hurt by data that folks apply to them, which is not reasoned in their thinking. So all the negative things are used against them. So an AI will take that and enhance the negativity, or has a potential to do that. These folks have these characteristics, therefore they are negative in the light of whom? So again, really understanding that there's a lot of values in here, that data use agreements and having the community understand what this is and how it's to be used. And then, of course, AI is built on large data sets, but it's also built on our ability to do it because of digital speed. A lot of these communities don't have digital speed. There's a huge digital divide. They don't even have electricity in some of these places. So it's one where, if you're going to really be able to understand and affect health in these areas, which in turn affects health in the rest of the world, digital communication, solving the digital divide, solving the understanding and the science of all of this is extremely important, and then training the human resource behind this. So anyway, I think those are things that regulatory bodies need to understand. And it's definitely one size fits all, or two sizes fit all, or five sizes. That's exactly wrong. I believe, in the communities I work in. But anyway, to kind of think like that, and if AI is going to be learning from, mistakes, it's also going to be based on mistakes that are in the data. But if you don't have the data from the beginning, you're not going to learn anything. So I just want to put that in there to augment what Marshall and Joy have mentioned.
Yeah, no, the systemic and structural impediments seem to be overwhelming in some communities. And I think that's the other aspect of this, that it is very dependent upon individual communities, cultures, that there are differences. And how does AI actually sift through those as well? Mary Joy, if you'd like to add your thoughts here.
Yeah, absolutely. And I'm glad that both Marshall and Neal have really honed in the importance of the sources of the data. I think the challenge, at least from where I'm sitting from, is how do we work collaboratively with our engineers, data scientists that design the AI piece? How are they providing the quality testing before it's even moved to production? Meaning there has to be some sort of like critical thinking and human in the loop in order to make sure that we are able to develop AI tools that are safe and that can be trusted, not only by the healthcare professionals, but also the way that it will impact our patient when they use these tools themselves. So I think that's where the policy can come into play in terms of our government looking at how this development of AI tools are being regulated. So this way it has that ethical and legal assessment and evaluation before they can even be moved as a consumer product.
These are great points, Mary Jo, and Joy, and Neal. And I want to add on a couple of those points. One was that I think we've all talked about bringing community in. And in some ways, it's really community is one example of it. Needs to be all the stakeholders at the table. This is not something where you want to leave it to the government, leave it to the free market. You want to bring in the people who develop algorithms. You want to bring in some people that will think about ethics, for example. So there's a variety of different folks. And if we don't allow this like group to do it as a whole, and we want to just silo groups, we're not going to have the best outcome. Second point I want to make is that we've talked about really is trying to find that wise balance between the free market and then regulation. The Europeans are ahead of the U.S. regarding policy around this, several years ahead. And so the European Union, they came out with guidelines around AI, like this last year, which are an attempt to do that. And they're thoughtful guidelines. And so on one hand, they didn't want to stifle innovation because it does them no good if they basically put their AI companies at a competitive disadvantage to the U.S. and other worldwide organizations. At the same time, they were very well aware of the concerns that Mary Joy, Neal, and I have been raising regarding when AI can go bad in terms of bias, discrimination, harming health. And so simply they come up with some guidelines where there's some uses which they would say are just like, you can't do. For example, like in the U.S. still, there are some of the criminal justice system, some of the sentencing guidelines in terms of how long a prison sentence you get are still based upon some faulty algorithms that penalize people of color, for example, right? That would be forbidden in Europe. I think like it can be done. And again, the key is you're not saying, well, it's just purely a regulatory approach or purely a free market approach. That's just not wise. You're trying to find that balance that allows us to be as innovative as possible and protects the public also.
Thanks, Marshall. And I think you're kind of highlighting some of the tension that exists there in how do we proceed with AI and dealing with these, again, large data sets and how do they impact specific communities. Kind of been talking about some of the concerns and the fears around AI in our community. What can we be excited about as Asian Americans, Native Hawaiians, Pacific Islanders about the future of AI? I'm sure that we could probably gather here 3 months from now and things might have changed already in that time. I mean, things are advancing that quickly. Mary Jo, I see you nodding your head there. It looks like you're ready to jump in with something here.
Yeah, absolutely. And we all know nurses are always on the front line. We are so burdened with so many things and also redundant tasks. And the workforce, of course, there's shortage. So we're hoping that this AI tool can help us in reducing the clinical documentation burden that we have. We chart so many things, right? Because if you don't document it, you don't do it. But with AI, we're hoping that it could assist us with these administrative tasks so that we could spend more time with our patient. We could have that compassion and caring that is really rooted in our nursing profession, and that we're able to really facilitate that trust with the patient, not just with AI, but because that's really the innate nature of nursing.
Thank you, Mary Joy. Neal.
Yeah, one of the things that really to me is exciting is a lot of the technology, especially the imaging type technology and even the scoping technology, if it can be read by AI and you don't have to depend on the specialists to be at the bedside to have a very accurate reading of the image to predict, cancer, not cancer, probability of cancer, then this can be used in very distant areas, very remote areas, where there is no ability to have this kind of human health resource to do this imaging. So to me, we're already applying that. And that's one of the big, I think, breakthroughs for very rural and isolated populations.
Mary Joy and Neal, you both kind of highlighted workforce issues and how AI can perhaps alleviate both the stresses on the existing workforce, but also how can it address shortages that we might have in other places. Marshall, do you have? Are you also going to be workforce, or do you have something else to bring to us here?
I was in clinic yesterday, and so we now use AI to help and then do an initial draft of a note. So it helps in terms of I don't take as many notes, and so I can actually concentrate upon the patient and listen, and basically do what I think clinicians enjoy doing in terms of really working with patients as opposed to addressing a computer screen and typing away, right? I'll give you an example regarding, I guess, the technological wow factor here. So that some of you may have been to the eye doctor and had pictures taken in the back of your eyes. AI can analyze these big data sets of these pictures of the fundus of the eye, and based upon just the pictures, determine what if the picture came from a man or a woman, right? So if you imagine that it can do that, it just shows the potential power of analyzing big data sets and just finding relationships and scientific findings that could help improve clinical care in the future. So there's a lot of potential.
Thank you. And I'll put it out there. Is there anything that we haven't covered that any folks wanted to make sure that we did mention?
I think it also allows us from a upskilling perspective, right? Because even though we know that AI could probably replace some of the redundant tasks and replace some of this work, it also offers opportunity for us to upskill our skills and generate more work related with data science. So I think that's what's exciting, at least from my field.
Neal?
A lot of AI can leave populations behind because a lot of it is based on producing something that's cost effective or faster. And faster and cost effective is not the coin of the realm in many places. And so one very practical thing I just can push out real quickly is that, for instance, in screening, the AI and machine learning has said, well, don't do any more screening in someone who's over 65 or 75 in this realm. Well, really? And so then they tell the doctors, well, you need to have a conversation. So it's things AI can't do. And we have to understand that limitation. And cost effective to whom? And so again, it's that value. And I just want to say that if it's based on cost effective and efficient, that is a value statement.
One thing we haven't talked about that is a good frame for thinking about policy is the so-called life cycle of AI or life cycle of an algorithm, which I would say there were 5 different phases of which policies should be thought about for each stage. One is, what is the AI being used for, right? So if AI is purely being used to make a buck in healthcare as opposed to improving the health of people, there's a problem there, right? And it should be the health of all people. Neal's point about we need to think about everyone, rural populations, urban populations, Asian Americans, a whole variety of different folks. So improving the health of all people. So what is the problem? A second part of the cycle is the data. upon which you build the AI. And we've talked about that in terms of making sure there's robust data about Asian Americans. Third is then how you develop the algorithm. And so, again, we talked about things like having the community at the table, transparency. So we understand, like, how is the algorithm being developed and are there biases built in? Fourth is how it is deployed in the field. And, for example, monitoring as a fifth element, too, of like, do we know how the algorithm and AI is performing among Asian Americans? Is it helping Asian Americans? Or, are these biased, inaccurate algorithms that are actually hurting Asian Americans? And again, this overall frame of how do you maximize the health and well-being of all people, no matter who you are?
Marshall, actually, you just did my job of summarizing kind of the key issues that we've been talking about here today. Do really want to thank all three of you for joining this panel. Like I said, maybe we need to reconvene in a few months and see what has changed even in just that amount of time. I mean, this really is an area of not just healthcare, but broader society that is undergoing such rapid change, but is going to have such a strong impact upon Asian American, Native Hawaiian, Pacific Islander communities. And I think the three of you have really crystallized what lenses we need to look at AI, particularly within the healthcare realm, and how is it going to interface with that and impact patient care and health outcomes for all Americans. So thank you very much, and thank you again to the Asian Pacific American Institute for Congressional Studies for hosting this.